Share the screen. Start.
Yes, so we are live. Good evening and a warm welcome to all the respected delegates on this live platform called Core Connect. Myself, Bhumit Patel from Corona Remedies. At Corona Remedies, we are top 5 gynec SBUs in pharmaceutical organization, and we always provide platform for different kind of scientific sessions like CRM and live webinars. So today we are here for Wings Fertility Conclave, and after completing 2 successful webinars, today we are here for the third series, and that is on how to reduce third-party donation in ART. Speaker for our today's other than Dr. J.S. Amin sir, and the master of ceremony for today's webinar is Dr. Smriti. Ma'am is a chief consultant at Wings IVF Patna. She is ex-assistant professor at NSMCH. She is joint secretary at BOGSCON 2022. Her education include MBBS. Ma'am has various publications in international and national webinars. Also, she is interested in infertility and adolescence health. She has achieved various awards like recipient of C. Javed Times Youth Icon Award and recipient of ISR Youth Icon 2023. Making further delay, I would like to hand over to this session to Dr.
Thank you so much for a very wonderful introduction and a very good evening to everybody. And I welcome one and all to this webinar and this Wings Fertility Conclave. It has been a very wonderful session for us, the series 1 and 2, where we had taken up stimulation and the luteal phase support. Mentioning today's, everybody can make out I'm traveling and still I have joined because it is such an interesting topic. More than being an interesting topic, the person who is going to deliver this has a vast experience in being able to connect families genetically. He is one person who has vision and interest in trying to give one their own. So the person whom I have known for so many years now, my mentor and a very respectable personality. So I would welcome Dr. Jayesh Amin sir. Sir is the CMD. He's the Chief Medical Director for the Wings IVF Group of Hospitals. And as I mentioned, he has his experience in the field of infertility for more than 18 years with 30,000 plus live births. And, we are still counting on those. And his successful cases in the recurrent IVF failure cases. And sir's latest interest is in immunology, and he's doing several researches and he's coming up with many publications. So just a small introduction for the person who actually needs no introduction. Sir did his fellowship of IVF and embryology from Lars Johnson, Sweden, and he's the clinical director of Wings IVF Group of Hospitals. He is also the additional joint secretary of the Indian Fertility Society, Delhi, the past chapter secretary of Gujarat IFS, past convener of the Fertility Preservation Society of IFS. We also have several training associations with the Amity University and Parul University. And sir has been mentor for several, including me. So it is my proud privilege to introduce Dr. Jayesh Amin sir. And sir, can we please have your talk now? I welcome you, sir.
Thank you, Smriti. Is always your speeches again inspire me to again and again to go deep in this subject. Sharing, do you want to continue? Yes, right? Yes. Now, I think so. My screen is visible.
Yes, sir.
Yes.
Yes.
Yes. So let us start, because this is a very interesting topic, as Smriti says, that how to reduce third-party donations, and especially I will be more talking on the egg donations, because it includes embryo donations, and there is a few words because surrogacy is a little bit difficult in today's scenario. So I will add something words that how can be reduce third-party donation, especially in the surrogacy. But as you know that the act which was arrived in 2021, and before the act, even I can say that it's all about the demography. It's about the all which populations you are catering. It's about the affordability. It's all about the subjective decision of the doctor and the patients. It's all about the liberalizations, and it's all about the emotional attachment of a couple. Before starting a lecture, I would like to say something about that. I'm not going to opposing the beautiful one of the part where people may require, but I don't want to overuse this part. Means that before starting my lecture that I can say the one failure, because I've seen a lot of file that one IVF failure, and in the second IVF, you cannot start donor egg. And again, when the donor egg failure, then you cannot advise the embryo donation, and that is called the overuse. I know that sometimes we, as a consultant on the back foot in a certain category, I know that when there is a patient, when they are in the back foot because of the affordability. But now rules is very strict, and I hope that from December or going onwards, that they are going to prevent the unnecessary egg donations. So I'm talking about the necessary that is required. I said when it is required, then yes, logically you need to do. But I said that when it is not required and when you are doing unnecessary, then how to prevent, that is what I'm going to discuss. Let's say something oocyte, because I want to discuss about the oocyte. It is the, I think so whole world is generated from a oocyte, the egg, the XO omnia, all things come from the egg. And in the late 1600s, a period that heralded the age of enlightenment by the scientists, that ovary, it is called, recognized that ovary contains the eggs. And these early modern scientists, however, held the mistaken belief that the follicle itself was the egg. But now we are very clear that the ovary, which is a genital organ which was generated, and they are having a multiple follicle, and we need to focus on the follicle which is generating the mature oocyte. So why today's lecture? And I'm going to put a lot of things that in my YouTube video, in my Instagram, in my whatever the social medias are there. And I'm putting the symbol that no donor egg. So it's all about the awareness, because you need to aware. India is a vast country. I don't know what is exactly the literacy rate and how people are understand the language discriminacy and a lot of religions and a lot of customs, which is really putting the female on the extreme part to get the motherhood. And where I think so that we need to still educate. India is very vast. So it is our job, I think so, requesting all the IVF specialists, those who are doing their IVF, they can have a lot of work on the social media to aware the population that still I say something, the very literate people don't know what is the exactly importance of the age. They feel something like that they fit at 40, and that is why you need to always tell them that now the science is going to be help it out. You please consult before 34, even you are unmarried or even you are married, you have a lot of options to get the pregnancy with your own genetics. So awareness is important. Now, what about the genetic background? Because certain things are to know before to start. For the egg, I think so egg is developed from the ovary, and the chromosome which is responsible for the ovary is X chromosome, and the gene which is responsible, I think so, the 13 to 21 and 23 to 27, anything, the mutation of this critical region on the X chromosome, which in turn leads to, so FMR1 and FMR2 gene mutations is often associated with a premature ovarian failure. And this is the quote that I want to say, that how this thing is originate, the world is originate. The God created a man his own image, and in the image of God created him, a male and female created, and God blessed them, and God said to them, be fruitful and multiply and replenish the earth and subdue it. And that is what we all people are doing, making a generations of our own. Why we are taking this fertility as a disease? Look at this past history, very past history, and which will say something about the desire of motherhood across the world. Even in the past, you say that Rachel's desperate pleas to her husband Jacob that give me children or else I will die. And this is the same situations in our all society, that getting a motherhood is so important. It is a reason of the divorce. It is a reason of the suicide. It is a reason of the family disturbance. And that's why we need to think about that exactly reproduction is so important. This is the same thing what I am saying, that the history suggests that how mother is compulsory in society. And this is the irresistible desire to have a child. So it is a history which suggests that motherhood is necessary. And which was later on the huge breakthrough, and which we all are enjoying, which was on the 1978. Within a 6 month, India is also having one IVF baby, which was unpublished. But we can have a first IVF born in 1978. And this, the journey which was start. But then why we are discussing about all these things? And looking to that we do have a more patients in our OPD, which is maybe decrease ovarian reserve. If you ask anybody that what exactly the number of the cases, which is as far as concerned the decrease ovarian reserve, they will always say that it is around 50 to 60% cases in a fertility. It's anywhere in the world, it is around decrease ovarian reserve. So it is increasing and increasing. The aged woman, the late marriage of the age, the cancer, the oophorectomy, the premature ovarian failure, and the lifestyle. And a lot more causes which are pushing that we do have a more patients of the decreased ovarian reserve. Now, let me tell you that if we are getting options of the egg donation, then egg donations will be increasing around 60 to 70%. But let me say that if you are having a good protocol, that is what I'm going to show you, that how you can reduce scientifically, how you can prevent, then I can say, yes, you can prevent the egg donations. And look at that, the movie, which is Wiki Donor, which was, it's really on the lighter mood side, but we know that what is the pain behind the man that also to take the own sperm baby. So this is also important, that increasing the obstructive and non-obstructive azoospermia and azoospermia cases in the community where we want to reduce the third-party donation. This is the same picture I want to say is for the lighter movements, and nothing else but about the surrogacy, that we know that the patient, those who are having an abnormal uterus, it may be what are the indications of the surrogacy is absent uterus or hysterectomized uterus, or women who suffered from repeated miscarriage, repeated IVF failure. And these are the cases where I want to say that don't take egg donations, don't take embryo donations, don't take surrogacy. These are the indications. I can understand that absent uterus is fine. This is the indications. I can understand there is a hysterectomy is the indication, but rest, and I can understand the medical condition is the indication, but rest of the other conditions do have a lot of options in today's era to have options of their own egg pregnancy, or might be they can have the own egg pregnancy in their own uterus. Now, which are the third-party donations? And these are the third-party donations in IVF. It's starting from oocyte, sperm, and embryo donations. And I can say that it is surrogacy. So these are the three donation which we can consider, which is very common in our routine practice. Now, let's say something before to act. I need to say something. Prevention is more important, because we all are that why all these things are going on and where we are. And I will just urge to the public community that look at this, what exactly you are playing, and why explaining my patients are always crying and saying, Dr. Jayesh, why I have a low ovarian reserve? What is the reason? And when we go ahead, then nothing will be found out. But then we know that at that time, my counseling is very clear, and I say prevention is more important. And look at the India, the nutritions. We know that we are talking and living in the cities, but this is the UNICEF which is saying that India is in a serious category, which is ranking in nutritions around 107. So to prevent, I think so, there are a lot of programs, and I'm so happy that my Foxy and my lot of UNICEF all together, they are getting a lot of programs for the nutritions, and that is more important. The Poshan Abhiyan, and which is more important, that the nutrition is the root of the cause of the ovarian health. And if the health of the mother is very poor, especially, they might be end up with a lot of tuberculotic or a lot of bacterial disease, infections, hygiene, everything together, nutrition, everything together will increase the egg donations. We know that money is the super scale of value, affordability. And that is why I may say that in India, like developing country, to reduce the egg donations, the health expenditure in India for, I think so, by the government is too low. And that is, I just say that, urge that should be. And I think so this government is doing, but there should be so many things which is required for the India for the spending the money in the public spending to increase the facility at a lower cost. And this is also one of the reasons that they want the faster success rate at lower cost, and they opt the egg donations and they opt the embryo donations. And I think so, I know that in the periphery, when there is an option of cost, and this is one of the reasons that they are opting the egg donations or embryo donations. I think so we need to have a balance between the rural and urban. And this is what I want to say, that we need to spend more money on the urban parts to rural part to reduce more public healthcare services, more AIMS and more other CSC and PSC, which is giving, or maybe the super specialty service by the tertiary center care, which include the IVF services, and which will reduce the cost burden on the patient. And we know that this is the reason why we do have a more egg donations in the periphery, where people don't afford the treatment of IVF will be there. Affordability, nutrition's affordability, now what we need to discuss. And this is why I think so Smriti will agree that there is something which is pollutions, and a lot of the substance which is available in the part of the Bihar, which is responsible for the male infertility. So what is it? That it is a pollution, it is the pesticide, it is a certain insecticide, it is which is the killer of your reproductions, the hormonal balance. And look at that, the pollution sound. Let me show that where we are and where the WHO is tightens the air quality norms, and we are coming in the very poor. So if you ask me, the Delhi, the quality index is very high, always more than 300. And this is what, again, we are not knowing, but it is reducing the health, the air quality, which is reducing the health, and pollutions, which is reducing the reproduction health and increasing chances of the decrease over in reserve, which might be one of the reason of the egg donations. So we need to understand these are the ranking that where we are, and we will, I think so, we have to, we all people to work hard, because when we are focusing on fertility, it's not only treatment is going to work, its prevention is more important. And achieving prevention, I think so, pollution, pesticide, and radiation, which are the three enemy and friends also, because we don't have any filter in my nose to clear the air, but I can clear the air by reduce the pollutions. The hygiene. And I'm very surprised to say that if you ask me that the most of the preterm delivery in the India, the 70% is basically hygiene. The hygiene is very poor in India, and the demography, and this hygiene will create the part of the world, part of the India. If you ask me Rajasthan, if you ask me the part of the northern part of the India, where hygiene is so poor, the sexual hygiene, the other hygiene is so poor that ultimately they are trapping in the certain a very permanent health disease, maybe tuberculosis, damage to the ovary and damage to the endometrium, and multifactorial disease damage, which in turn leads to insist the doctors, the specialists, to go for the third party donation. So hygiene, I think so, again, the most important part. Hygiene, this is what the Indian scenario. Still we are far to make something to improve the hygiene, which is not going to be improved until and even we are not going to back the basic necessity, which might be toilets, will be there. And for a female, it is so important to maintain their hygiene, vaginal hygiene, everything which is important. What about the pesticide? I'm still stable on pesticide. I know that we are still far behind using pesticide compared to the western part of the world. And look at that, we are only 1% that of the part of the world pesticide consumption that we are using, but still we are shouting, and yes, we are shouting. And still that is also responsible for the certain reproduction health. And this is what the pesticide, and we identify the watersheds, means we can say that certain things, the water scarcity, all this together, the India in trouble, specifically in the pesticide. So what we can do? Should we buy the organic food? And look at that. This is the cartoon which says that fish has mercury, meat has the E. coli, veggies have the pesticide, desserts cause obesities. So we will have the health conscious, nothing for dinner special. We need to understand, because these all things will give you. And what we are doing, that for a pesticide is all about the consumer education. We remove the pill of the vegetables and fruit. This is what important for that. And this is why the multifactorial etiology of that lifestyle, aging, all these things which will lead to the damage to the testes and the ovaries, which in turn leads to the egg donations. How to improve? Look at this work pressure, radiations, food additives, lack of exercise, environment population, pollutions, unhealthy lifestyle. So we need to reduce this. All are having that we will come to the circle to reduce and change our lifestyle. Change to lifestyle. This is exposure to radiations. This is exposure to stress and nothing else, but it is increasing smoking. And I want to highlight today that because in the metro cities like Delhi, when I go to there, the smoking, which is very dangerous. And this is also one of the reasons we need to educate the female that planning the pregnancy, you need to quit or you have to reduce. And this is, they are saying that how they are reducing the fertility power, maternal smoking effect. It is also killing the uterine ovary also. It is also increase ROS, is affect the meiotic maturation of the human oocyte. And please quietly say something about that, quit smoking. You need to quit smoking. And that is another responsible, the prevention part. And these are the alcohol guidelines that you need to follow. I cannot say that quit, but I can say that these are the guidelines that you need to follow when you are planning the pregnancy or when you are having a pregnancy, which is responsible for your the worst scenario of the oocyte condition, which in turn leads to a breastfeeding. So these are the do's and don'ts. Prevention. I will go by the treatment, the healthy diet, avoiding substance, supplement under the doctor's supervision, light exercise, stress management. These are the healthy diet and healthy habits will be there. So these are the good habits that you need to go for. These are the good diet that I want to say, that folic acid, omega-3, vitamin C, the holistic approach. Now, poor responder could be treated by the good quality of the hormone, but if they don't have a nutrients, then how the cell is going to work to produce the blastocyst? And this is one of the holistic approach that you need to give and explain. And I think so I started to my patient when there is a multiple failure and they want their own egg, and if I have a time, then I think so this is the diet habit. These are the quitting. And I say that things to avoid. And I think that this is the best food for the IVF. And I think so I will like to advise them. These are the important things which is required, the holistic approach to improve and decrease the egg donations, which is so important. The small thing that coffee is also important. Don't go by the 200 milligram a coffee. A different type of the coffee is having a different role. So I say quit coffee. I say quit black drink, maybe Coke. I said reduce your tea amount. So these are the 200 milligram of caffeine in your beverages, which you need to think about it. Now, nothing is beyond law, because how I can prevent, this is all preventions. But I know that in the act which was published in India, that ART Act 2021, I think so, it's a beautiful act. It's all about to understand, regularize. And I think so it will give awareness to the patient that how we are reducing what is exactly egg donations. And also it covers the donor and reduce the donor, so people will understand to plan the pregnancy earlier and we will get more patients. Our whole TG group will change. So I will be very positive that looking to the 2021 Act, but Act is important to punish the people, those who are doing unnecessary egg donation without informing the patient, which is also important, because this is a law, this is a world where there are lots of type of the people where we need to regularize that, what is the indications, and we need to do the egg donations according to the indications. Awareness, yes. And why I'm putting this age awareness? If you have a less than 30 planning the pregnancy, if you are not planning, there is an option of oocyte cryopreservations and compensate in 35 to 40. This is the compensate, maximize of ovarian response to the stimulations. So where we can go by the duostimulation, where we can go by the augment, or where we can go by the maybe something PRP and stem cell therapy. But when you are having more than 45, and this is the slide that I want to say, that don't cross your age of limit for a planning of pregnancy. And I think so somebody has to put to the community that exactly what are the options available, and the reduce the risk. We have a PGTA and also the single embryo transfers in the advanced maternal age. So this is the same slide. I want to go like that you need to aware. These are the awareness, that 10 things to do, what you can do something, fertility check programs, right? Detoxifications, that what is the regular importance of the regular sex, what is the importance of the healthy eating. These all are important. And I think so this awareness program is so important to reduce. And this is, look at this. And we are having a fertility awareness week since before 2 days, or I think so 1 week back, where we have a lot of programs on our social media to engage the people, to learn the people, to connect, to show them that what is exactly infertility, aware, and use the certain things before your age to prevent the egg donation from the society. Now we are coming on the treatment, the egg donation, sperm donation, embryo donations. What is the oocyte donations indications? Advanced reproductive age. This is more important. Resistant ovary syndrome, that can be treated. That is what I am saying, that. Poor oocyte and embryo quality. I think so the poor oocyte will be, and embryo quality is all about your stimulations. That is also I am saying that it's not be indications. Recurrent IVF failure, I think so this is not the indication in today's era, because you can treat a 4 IVF failure with their own egg, with if there is egg will be there. And recurrent pregnancy loss, where also I am putting, as Smriti rightly say, that we are now more focusing on the immunological science and genetic science, because now development. So look at the donation indication. By looking to that, I think so the menopause is the only indications, and extremely poor AMH, where all other measure is failed. Then beside that, I think so there is no indications for the oocyte donations. So that's why I say that premature menopause, the autosomal dominant genetic disease, means you need to change the oocyte. But the most important is threshold of a clinicians and patient to work on low AMH. Another indications are threshold of clinician. And this is what I want to say, experience clinician, experience embryologist team, and expert counseling team. So I urge the populations and doctors that there is no indication in the low AMH when cost is not concerned. The cryoaccumulations and the regenerative therapy and pushing the patient and counseling again and again will do reduce the lot of people. I don't say all people, we do reduce the lot of people as far as the act concern and demand and supply on the future. I think so we need to push the patient to get their own egg pregnancy. The relative indication which was seen, that multiple IVF failure. So patients are tired, and that's why I say that choose the pathway, like not more. This is the time to choose your pathway of treatment, intention to treat. Don't explain the patient the new generations, the trial concept, rather than to treat the trial concept. This is more important. And the most important is we are looking for the insurance and the involvement of the government to treat the poor patients, that they will get the more services from the government and they will not opt the donor egg. Literacy rate, it's all about that education is more important, and sometimes patients are unaware what is exactly going on, which might be taken care by the act. And that is what I am saying, that people do have a mindset that if I have a more age, I require. There are a lot of people, those who advise that more than 35 donor egg is better. And that is why I say that cryoaccumulations and PGT, the genetic disease, you have a 3 consecutive abnormal baby, changing an egg is not option, but inquiring the genetic disease and treating is more important. And I will urge that every IVF center should have to have a certain economic IVF approach to treat the people, those who don't afford in private. And this is again another way forward to reduce the egg donations. What we can do, the changing, that is what I am saying, that which gonadotrophy in that, which strategy that we can use, which will reduce the egg donations. When you are having a good number of the egg, but still you are advising the egg donation, that means you are not regulating the ovary stimulations. When you do have a less AMH, then what exactly ovarian rejuvenations will do? And when ovarian rejuvenation is failed, the last therapy, which is now we are already implemented, it is a drug independent therapy. It's no drug therapy, which is called dormant follicle activation. So now we have to think about that anything less than 42 years in a female, specifically counseling, cryoaccumulation, changing in the gonadotrophin strategy, rejuvenations, and the dormant follicle activations will, these are the three things which will be step by step will prevent the egg donations. So we need to, when we say something about that, when we say something gonadotrophin dependent therapy, then we have a three strategy which is more important. We need to highly individualized. And when we say highly individualized, we need to inquire regarding the biomarkers. And then we have to accept the cryoaccumulation strategy. So how to manage the uncertainty when we do have a less number of the eggs, when we do have a hypo response, when we do have a response which is not able. And before I start, I really say something that today I have one patient of 27 years old, a polycystic ovary, and which was explained in the territory of the Rajasthan that you will not get anytime your own egg pregnancy except donor egg. And these are the things which is so important. Why? You can manage the all uncertainty, including OHSS. Why you are saying that you will never conceive? Because of the OHSS. So before that, I can say that, do you have a remote control to manage this uncertainty? And if you ask me, this is what the journey from 1978, we are on the same page. If we are on the same page that the first baby which was born by 13 trial, I said no. And that is what we changed toward the phase cycle transfer to frozen. And I think so PGTA, which is again a treatment to prioritize the embryo to reduce the unnecessary transfer and decrease the abortion rate, which improve the psychology and intention to get the better treatment by a community. Before that, we should know about that 7 million oocyte. So we need only 7 million oocyte, which was given to the female, which is at the birth, it is around 1 million. And I think so only 400 to 500, which is going to be ovulate and which will give the pregnancy. When there is, why do we need biomarkers? The managing uncertainty. And why I am discussing it? Because this uncertainty will lead to a multiple trial. And that multiple trial lead to egg donations. So that's why I already say that we need to, the ovarian response is more important. And I will say that how you can check individual ovarian response, who will get low response, who will get proper response. And that is what the polymorphism that I want to discuss. And this is the journey from 1990 to 2060, where we can choose the stimulation by looking the patient age and the weight. And then we will look in the stimulation by FSH in the era of before 2009. And after 2013, will be much more focused on AMH and AFC. We all people are much more focused on AFC. AFC is a still standard, gold standard for exactly advising the oocyte yield compared to the AMH. But then what is exactly uncertainty? When still there is uncertainty, is all about the receptivity. And that is what I want to say, that this is called the polymorphism, and which is going to manage the uncertainty to reduce. It's all about to use not to one single parameter of age. It's all about to use multiple parameters, including AMH, AFC, and age. This will reduce the uncertainty. So don't use a single parameter in your practice. Use always multiple parameter, which will give you the sensitivity and specificity higher. The area under curve, the sensitivity is 0.8, which shows that the higher sensitivity when you are using age, AMH, and AFC. Time is important, the biological clock, and that is what you need to say. If you want to prevent, if your biological clock is running away, that is what I'm discussing, that increasing age is going to be increasing the aneuploidy. And lastly, I think so when I choose the biomarker should be accurate, reliable, and stable. And we are using AMH, but not only AMH. And that is what I want to say, that this is the study which says that if you are using only AMH, you do have a lot of variation, intercycle and intracycle variation will be there. So, and the intra-observer variability. So what is variability? That is what we can see by that, the variability we can easily find out by the combination of the AMH and AFC, both. That what I am saying that, and these are the value which we decided we are practicing. It's not depending only AMH. We are dividing that when the AMH is more than 2, it is a good prognosis patients. When number of the oocyte are increasing and less than 2, it is proven poor responder will be there. Then how can you make the Taylor approach? And that is what we are giving a Taylor approach, that when you are having a less than 2 AMH, we are using always higher dose of the gonadotropin, but not more than 300. And when we are having a less than 2, more than 2 AMH, we are using 200 to 225 IU of recombinant FSH will be there. So we are individualizing. But the thing is that the hyporesponse, even though if there is a hyporesponse, then what is exactly we need to, because we are using this recombinant FSH, and if there is no follicle, that means the follicle oocyte index is less than 50, which again less number of the oocyte, less number of the embryo, more failure, and people push to go for egg donation. How to treat this hyporesponse? The follicle output rate is only 30%, 15 M2, which will be retrieved at the end of the day, you are having only 4 M2. So this is called polymorphism, and that you need to treat. Beside this, all the differential diagnosis of low gonadotropin starting dose, asynchronous, technical issue of the trigger. If all this not there, then this is the genetic polymorphism. And this genetic polymorphism at Wings, we are doing FSH and LH polymorphism previously. And we know that by this polymorphism, we can easily treat adding 75 IU of HMG, which is bare minimum to treat the hyporesponse in a good prognosis patient, younger prognosis patient. So now we started a dose of 200 plus 75 or 300 plus 75 to use this uncertainty. So there will be less uncertainty, less number of the IVF cycle, less money involvement, more oocyte, more euploid embryo, and there may be less failure and less chances of egg donation. So to reduce the uncertainty is also one of the part to reduce the uncertainty. Now let's say something about the Poseidon group 3 and 4, which is, I think so, the patient, those who are having a less number of the oocyte. So their AMH is less, their AFC is less. How we can stimulate this type of the patient, the Poseidon group 3 and Poseidon group 4. And this is what I am saying, that in polymorphism, I am always adding 75 IU of HMG if there is a homozygous polymorphism. Our stimulation protocol will be 200 plus 75 or 300 plus 75 depending on the AMH and the polymorphism will be there. And this is, I again say, Poseidon group 1 and Poseidon group 2, that you can add LH on the day 2. So don't add on day 6, right? And I think so recombinant LH with the second line of the treatment, I still feel that HMG 75 IU is still important to play a good role to get the good number of the oocyte. What about the Poseidon group 3 and Poseidon group 4? Poseidon group 3, we are using 300 IU recombinant FSH or 75 IU HMG. And Poseidon group 4, we are always using estradiol down regulation with 225 combinations, which always give a good response. And if it is not responding, then we will switch over to HMG or recombinant LH at the end of the day. Now, this is another theory that I want to say, that still in the Poseidon group 4 or Poseidon group 3, if you have a less number of the oocyte, then we know that the prediction model, if you have a less number, then less embryo. Now, how we can go for a more number of the embryo? That means we need to retrieve more number of the eggs. And this was the theory which was explained later on, that one menstrual cycle do have a 2-wave or 3-wave. 62% or 63% of people do have a 2-wave. That means the follicular wave and the luteal phase wave. And where the theory which was started, it is called duostimulations. So to get the more number of the oocyte, but let me tell you that there are some weakness and threats. Still the studies are not published. I am not in favor of duostimulation. Do 2 stimulations in 2 cycle, 1 cycle. I am more in favor of double stimulation, and that is called cryoaccumulation. So to reduce the egg donation, you can have a cryoaccumulation. You can stimulate, you can wait for 1 cycle and see that which wave is important, whether follicular wave is important, whether luteal wave is important, whatever the wave, because random start stimulations can give you the better oocyte, number of the oocyte you can reduce, but I still not believe a duostimulations. And we are always having a cryoaccumulation to reduce. So we explain the patient, especially when the age is higher, AMH is low, we can explain the patient for 1, 2, 3, 4 stimulations and we accumulate it. But this all required the proper counseling and also the money. That is more important, that money is important, or you can reduce. I already say that it's all about the holistic approach and to start the add-on, how I can reduce, how I can increase the potency of the oocyte, because at the end of the day, the potency of the oocyte, the adjuvant, which is going to increase the number of the oocyte as well as the quality of the blastocyst. If you see that the green line, and what they say that if thicker the green line, they have a higher effect on the number. So we can say they have a more effect of adding LH. Yes, all the patient, those who are advanced maternal age, to improve the number of the oocyte and quality of the oocyte, we are always adding LH or HMG, LH or SCG. And we are always having a treatment with the CoQ10. That is what we are doing in our clinical practice. Though the studies are saying that testosterone gel and DHEA both are increasing the testosterone in the ovary, will increase the number of the oocyte, but our experience is still not better, and we are not using testosterone and DHEA, which will be always a second line of the treatment. The patient is waiting for the other stimulations. So the current analysis will say that DHEA, testosterone, and CoQ will be the evidence-based medications you can give to increase, especially to prevent the egg donations and getting the better quality of the blastocyst in the Poseidon group 3 and Poseidon group 4. Now you have a better quality of the oocyte. You are managing the variability of the number of the oocyte by genetic polymorphism, adding LH, everything is fine. But the consistency, and this is what my lab, we have a closed system, we have a time-lapse technology, we have a lot. It's all not, I'm saying that everything is increasing, but it's all my passion that how we can reducing the temperature sensitivity of the oocyte, because oocyte is more sensible to the temperature. And we always able to manage the temperature to increasing. And we are using the closed system specifically for the poor responder to reduce the third party donation. Another part is more important, the air quality, and there is no doubt about the VOC, which is directly going to increase the ROS and other factor, and which will in turn reduce the blastocysts. The good hormones, the good number of the eggs, the clinician is good, everything is good, but the filters are bad, the VOCs are higher. And this is what's more important. We have a centrally connected VOC observing system, which will always cater my all lab that what exactly my VOC gives alarm. So this is what we are putting efforts to improve. The thumb rule for increasing oocyte power. See, these are the thumb rule. You should not do pickup before 36 hours. You should not denudate the oocyte before 39 to 40 hours. And don't do ICSI before 40 hours. And these are the things which is so important, because people are freelancing, and that's why there is a decrease in the efficiency of the blastocysts, and you may end up with the fertilization failure, and it required more and more. It's required more and more egg donations. Which are the sperm preparation to reduce the sperm preparation technique, the frequent ejaculations, semen collection only before 2 hours of ICSI, double density gradient method, microfluidic novel technique in certain case, and we are using sperm slope and count is less than 1 million. And IMSI is always there in the male dominated infertility. Is nothing the oocyte, because oocyte need to heal the sperm. And if your sperm is less damaged, DNA damage, then oocyte can get a more power to heal the sperm. And it will reduce the egg donation indirectly, because you will get the better quality of the blastocysts. Nothing else. I can say accumulation, accumulate, accumulate, and accumulate. And I will like to say my patient, I do have a oocyte embryo prediction model, and I explain that what are the number of the oocyte to require one euploid blastocyst. And they understand that when their age is higher, where AMH is low, then they need more oocyte, but it is not possible. So they need cryoaccumulation, and this is the explanation counseling towards to reduce the third party donations will be there. Blastocysts, yes. Now a lot of studies are coming, and they are still saying that blastocysts in poor responder. It's all depending upon your lab. It's all depending on your team, that how confident you are when the less number of the eggs, even you are confident to culture the embryo up to day 5, which is required to select the quality as well as the genetic screening of the embryo will be there. Now, which are the indications why we are doing? We say that another indication last that, so recurrent implantation failure. And these are the different cause of the recurrent implantation failure. And as we know that in the natural conceptions, only 25% live birth, the rest of the other thing are clinical miscarriage, the early pregnancy loss, and implantation failure. So ultimately, to prevent the multiple trial, you need to open the Pandora box, the black box of all these things, and how you can open early. The early you open, you reduce the trial. The early to reduce the trial, people will multiply their cycle, and they will get their own egg pregnancy better. So we are always in the favor that egg is the responsible, and that is we are always focusing on the more qualitative oocytes and more number of the oocyte. What about the embryo? We can say, should we promote? I already say that day 5, yes. And this is the blastocyst clavage. So we all are doing blastocyst basically to reduce the third party donations, because the day 3 embryo, we don't know which day 3 embryo will enter into blastocyst, but it's all depending upon your embryological conditions, your teamwork. To reduce the failure, because recurrent implantation failure, if you go beyond 4 failure, then there is a symbol of failure and you will go for the donor egg. But as you go and apply certain strategy of blastocyst transfer, hysteroscopy and genetic screening and co-culture, which all thing will lead to less failure and they might get early pregnancy with their own egg. So applying a good strategy in a targeted group patients, especially the multiple implantation failure, which will be the way forward. And it's all about that. The genetic screening is a way forward beyond the freeze-all strategy. Add-on treatment is there. Though the multiple publications are still putting a bias of mosaicism, still the trend is toward genetic screening. Look at the USA, look at the Australia. When I ask the consultant, the 80%, the good clinic, the tertiary clinic do have a genetic screening in their clinic to improve the success rate. So this is what about I can prevent to do blastocyst transfer, hysteroscopy, genetic screening. But when we say something about the why there is a failure, we need to go beyond the 25% cause is endometrium, and that we need to explore. And what we are doing for that, because if you don't explore the endometrium, the black box, then again there is a failure and it will end up with the again donor egg. To reduce that, we know that we all are using sonography. We all are using only normal sonography. I think so color Doppler has having no value. But the most important part is synchrony. The synchrony of the embryo and the endometrium. And the simple thing that we are doing, that whole industry is shifted toward freeze-all. In the India-like country where nutrition is a problem, the India-like country where there is a poor responder are 60%, the phase cycle transfer is not a good way forward. Multiple failure will reduce that potentiality to spend the money towards the IVF cycle. So always precise, meticulous approach to transfer where freeze-all and day 5, and again, after genetic screening, in the certain cases when the number of embryos are lesser, the strategy which we are opting, again, it is called ERA. I don't think so. I don't want to say something, ERA will improve the live birth rate. There are a lot of things which is related to improve the live birth rate. But it is individualizedly important to use the ERA, and that is what we are using ERA. As I say, that 75% reason is because of the endometrium. Now, the other thing is optimal embryo transfer strategy in poor response. It is include, I already said, day 5 ET, freeze-all, cryoaccumulation, blastuation. These are the things which was published and people are now having, because previously it is not published and people still worried, but I think so. Now India is also picking up the train toward the blastocyst and genetic screening, especially in the poor responder, and especially the advanced maternal age and multiple implantation failure. And this is my paper, which was saying that individualization, personalized individualizations. I'm showing only the part of the paper which shows that 21 to 25% receptivity changes and multiple implantation failure. And these are the patients where we have a 219 patients. Out of that, if you ask me, 122 patients do get a pregnancy by putting them on a personalized embryo transfer. So this is again the way forward. But then what we can do, that even if we failed after this genetic screening and the ERA, genetic screening of the embryo or genetic screening of the endometrium, which is called as ERA, we still fail. And that is what that failed, or we can have a recurrent pregnancy loss more than 2. Then what we can do? Nothing else. And this is what we are doing, that we always inquire the bacteriological science. And these are the panel we are using routinely when we transfer, and we will inquire regarding the bacteria which is responsible for the infections. And that is also culprit for the implantation failure. I used to also see these are the different molecules, the histopathology, the CD138 for diagnosis of the chronic endometritis, the acid-fast bacilli because of the endometrial tuberculosis, the BCL6 for the chronic endometriosis, which prevent the implantation, and the CD56 to check the level of the uterine nasal killer cells. So this will give the general idea that what exactly going on in the patients to prevent. This is the primary test that I will advise my patients when I'm treating all the patients, taking the biopsy nowadays during the pickup and sending everything and confirming that she's having any chronic endometritis, and then giving them antibiotic and probiotic. These are the tests, the 16 sRNA sequencing, which will show that lactobacillus dominance. And these are the studies which says that lactobacillus dominance is important for the better implantation and the normal triangle, and that is called iron triangle. The balance between the immunity and the implantations, where you require the lactobacillus bacteria. So this is how another case, another indications for the egg donations and embryo donation is recurrent pregnancy loss. And that is how this is the ASRM publications, and which is saying that how to treat recurrent pregnancy loss. Screen the weight extremes, alcohol, smoking, cavity check, screen for APS, endocrine testing, all management of 1, 2, 3, 4. If it is all managed, then consider prophylactic vitamin D supplementations, provide psychological support. If you have a POC positive, that POC is showing something, then there is a karyotyping of the husband and wife. But nowadays, the ASRM guidelines, if all 4 are not effective, then husband karyotyping is also one of the way forward. So we are doing husband karyotyping, and we are also doing expanded carrier screening. So this is what we are doing, expanded carrier screening to find out any carrier. So nowadays, not required of CGH microarray. It is all about that karyotyping and expanded carrier screening to find out the genetic mapping of the patient, that why there is recurrent implantation failure and why there is a recurrent IVF failure. And this is the most important part, that beyond that, suppose we already find out the PGTA, the PGTSR, the translocations, the reason behind to reduce the egg donation. But when there is a multiple failure, it is all about the last part is the crosstalk. And look at that. We know that husband and wife, these are the different crosstalk, like that the blastose is also having a part where husband is there, and they are having a talking with the endometrial surface of the wife. And that is what I want to say, that we are exploring, and my 10 patient pilot study, which was accepted in this next ASRM, where we are putting the 10 case series of the pilot study, the role of HLA typing and recurrent pregnancy loss. And it is a huge subject, but we are saying that now we are going on immunology and inquiring the HLA typing and going deeper, that which type of the response, whether it is rejections and receptions. The shift is toward the Treg cell or Th2 cell, which are the pro-inflammatory and inflammatory, anti-inflammatory cytokines that we can see and we can analyze, and we can treat the recurrent pregnancy loss. And this is how the report will look. And by that, we can find out different HLA typing. And this HLA typing do have a recommendations, whether you require the lymphocyte therapy or intravenous immunoglobulin therapy or what. And this is a very deeper subject, is required another one more lecture. But I can say that to reduce, because to directly say that third party donation, these are the again opening the box of the Pandora, that where we can advise to patient to go for the other treatment. And that is what we are also doing, the lymphocyte, that means the Treg cell estimation, those who are having this is my pre-LIT workup, and where we find out the Treg cell, the TNF alpha, the CD3 and CD4 plus, CD25, and all other these uterine nasal killer cells, and also the certain interleukins, maybe all IL-2, IL-17A, all. And then we can decide that what exactly patient required when patient is having a recurrent pregnancy loss. And we are doing low dose lymphocyte immunotherapy. And this is the summary of meta-analysis of 2016 of low dose lymphocyte therapy. And it was effective. And this is for specifically for Asians. I want to say that we will put our own efforts to publish our own data that how LIT is effective in recurrent pregnancy loss. This is what we are doing, how low dose LIT therapy every 15 days interval, and then at the time of beta SCD positive again. I know that the still IVIGG and the other treatment, the intralipids, which is still it's still disputable. And we want to prevent, we want to see something, what will be the role in the recurrent pregnancy loss. Still, I don't believe, I am not going to comment that this is going to be fascinating to prevent the recurrent pregnancy loss. But beyond that, I already say that which are the refractile endometrium, the thin endometrium, it is also one of the reasons to go for the surrogacy. And this is what you can say that to prevent the surrogacy, what are the which are the other things that you can do? To prevent the surrogacy, hysteroscopy is one of the beneficial intervention. But as I know that we are doing a lot of other things, that subendometrial PRP and subendometrial stem cell, that is what we are doing. I know that people are saying that it's still not responding, but it's all about that the surrogacy is not explainable in the society, and still it is commercial surrogacy is a ban in Indian next 2021 Surrogacy Act. So we still believe that let's have a strategy putting intra-arterial. Today we had done one intra-arterial stem cell therapy, and let's put something like that, how it will improve the implantation. And what about the rejuvenation therapy beyond it? So when there is a low ovarian reserve, to prevent the egg donations, we are doing ovarian PRP, and we have a certain algorithm. The algorithm which is saying something, the volume of the ovary, the number of antral follicle, and the AMH. These three things together, and the previous response by the gonadotrophin, the fourth thing. Together, I will segregate my patient that this patient is required ovarian PRP, and this patient is required ovarian stem cell therapy. And also, I can segregate that this patient is required the dormant follicle activations. We have completed a lot PRP patients, and we are trying that the PRP will effective within 20 to 60 days after the first PRP. It is intravaginal. We never do PRP until and even ovary is assessed vaginally. If ovary is not assessed vaginally, very smaller, atrophic, fibrotic, then and then I think so we need to do laparoscopically. The rest of the all ovary, it's all about the experience. This is what we are doing PRP in the poor ovarian responders. This is the stem cell that also the studies are coming that it is favorable. And last part is the drug-free in vitro fertilizations of the follicle. And that is what today's also we have a one case. I think so we completed 10 cases now. And we are moving on this a part of surgery, laparoscopic surgery. We have a unique, we are not doing a strip of the ovary and chopping the ovary one by one, and then we are inserting in the sleeve of the ovary, which is very difficult and too tedious. And I don't know it is practically possible in the all ovary or not. And that's why we made our own protocol. We are not removing the partially remove the cortex, but we are removing the cubicle, only the punch biopsy of the ovary. And my regenerative specialist team, we made some regenerative specialist team in Ahmedabad. With the support of all the team, we are preparing a solutions with the 3 ml solution, where 1 ml is contain ovarian cortex cell, the second is cortex cell, then the second will contain the primordial cell, and third will contain the growth factors. And we are going to inject one by one transvaginally. Today's in the afternoon, we had done the same. to the patient those who are 39 years old and she want their own pregnancy, and these are my desperate intervention that we want to get my patients on my table, that to increase the number of the oocyte retrieval after doing dormant follicle activations. And you can see something that this is the publication that they say that 11 oligomenorrhea patients, and they do this type of laparoscopic surgery and insertions. And these are the different 11 patients, which will there, and they have a number of oocyte retrieved, and accumulated oocyte is 18, 21, 3, 25. You can say that, you can see. And there is a natural conception which was observed in patient number 2. There is a pregnancy which was observed in patient number 6. So there is a role. So we are also looking for that, this type of the case series, the patient those are having a failure to produce the eggs, that regenerative therapy is having a role in the extremely low AMH. And don't refrain extremely low AMH, because I think so. I don't put a paper, even 0.1 AMH is having a certain success rate. And our threshold to work on AMH is we never bother on AMH. We are always focusing on antral follicle count and regenerative rejuvenation therapy. And we are able to get, but yes, you need to counsel the patients, and patient do have a literacy rate. And also the finance is a concern, because these are not the treatment which is cost. It's not cost. It's a costly treatment. So these are things is that fertilization rate after this study is for 68.7. The high quality embryo is 56.9. Number of the patients with pregnancy is 4. And number of the patient with miscarriage is 1. And number of the patient with cryopreserved embryo ready for embryo transfer is 4 out of this 11 patient. So it's a good study which was started in Japan. And we started by our own that how we can produce the dormant follicle activation. We are urged to say that to all the population, that if you have this type of the patients of POI, where we already started with our regenerative specialist, the dormant follicle activations, we are not doing more laparoscopic damage and more cubicle. We have our own therapy, which is, you can come and see that how we are doing this in dormant follicle activation. So conclusion is very clear. The gonadotrophin and cryoaccumulations, follicle less than 3, then regenerative therapy. Choose the good way for the frequent follow-up, genetic testing in advanced age without augment, activating dormant follicle treatment, and gene therapy and artificial ovary might be the future to reduce the third-party donations. So this is what I am concluding my lecture, that we are doing genetic polymorphism to reduce the hypo-response. We are adding LH in the poor responders to increase the number of the egg as well as the quality of the blastocyst. We are adding sometimes testosterone gel and doing regenerative therapy and activating dormant follicle with blastocyst culture, hysteroscopy, cryoaccumulation, synchronizations, and the genetic screening is a way forward to get the maximum out from a female who is she basically indicated for egg donation in a certain indication. Thank you so much.
Thank you, sir. Thank you for a very nice talk, for giving us the vision that was absolutely invisible to us. The regenerative therapy that you have spoken about. We have very nicely also taken a few take-home messages of being a good counselor, for being more tolerant with the patients, and also opening the black box. I have seen you open it a couple of times, sir, and I'm sure that many will be benefited by that. Thank you so much for a wonderful lecture, sir.
Thank you. Thank you, Smriti. Thank you, Corona. So we will be in touch with our next program is World Fertility Conclave. I think so. Dr. Sandro Esteves, he's going to speak on management of male infertility. So that will be on, I think so, the date will be on 22nd May will be there. So till then, good night to all. and we are always happy to share the knowledge. Thank you so much, Smriti. Bye.
For the questions, we can have the questions being we'll be taking up the questions from people if they are interested. They'll be able to message to us.
If there is any question, is there?
Sir, I can see there is no any questions.
Okay.
Hello.
I think because we've not put it, but somebody can get in touch with us if there are any questions, especially on low AMH and about the cryoaccumulation that sir was talking to us about. We'll be able to take questions, sir, and we'll put it to you.
Thank you.
Thank you so much, sir. Thank you so much. Thank you, everybody.
Thank you. Thank you, everyone. Yeah.